Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. We rheumatologists know calcium pyrophosphate deposition disease, or CPPD, through one of its classic presentations, pseudogout, a swollen knee or wrist, an acute flare, crystals in the synovial fluid. But that's only a small part of the story. What if many patients we diagnose with refractory inflammatory arthritis, polymyalgia rheumatica, or erosive osteoarthritis actually have chronic inflammatory CPPD driving at least part of their disease? And what if one reason we're missing it is that we're simply not looking in the right places? My guest today is Dr. Janeth Yin. She's Associate Director of the Musculoskeletal Ultrasound Program at Massachusetts General Hospital and one of the leading experts in musculoskeletal ultrasound in rheumatology. She previously served for a decade as Director of the Rheumatology Musculoskeletal Ultrasound Clinic at Tufts, and she's co-author of the Clinical Atlas of Musculoskeletal Ultrasound in Rheumatology. And she also contributed to the development of the 2023 ACR EULAR classification criteria for CPPD. In her clinical practice, Dr. Yin has become increasingly interested in the many phases of CPPD, from patients who appear to have seronegative rheumatoid arthritis or polymyalgia rheumatica, to those with unexplained joint damage, tendon rupture, or chronic synovitis. Her work suggests that CPPD may be far more common and far more consequential than many of us realize. In this episode, we discuss why chronic inflammatory CPPD is often overlooked, how it can mimic other rheumatic diseases, the role of musculoskeletal ultrasound in diagnosis and management, the structural damage associated with the disease, and where the field may be headed as we search for more effective treatments. Enjoy. Janeth, welcome to the show.
Hi, John. Thanks for inviting me. I'm excited to talk about this topic that is something I see on a daily basis.
It's interesting. CPPD, it took us a while in this podcast to get somebody to talk about CPPD, but we've had here Sarah Tedeschi to talk about the classification of CPPD that she was involved with. We've had Tristan Pascart to talk about sort of novel treatments for CPPD. But I think the issue and the challenges remain is that this disease is probably underdiagnosed, even in our rheumatology clinics. And that's why you're the perfect person to discuss about how we can improve our ability to diagnose these patients with ultrasound. Do you think that's true? Do you think that this is something that many rheumatologists are missing?
Definitely. And I actually like what you started saying is that's what I want. You've had Sarah Tedeschi, you have a Tristan Pascart. We want to have people become more aware of this because this is something that I always say, we are all seeing it. It's in our clinics and we are not that aware of it. I call CPPD like the sleeping giant. It's there, it's silent, destroying the joints of our older patients, and we're not realizing. And so that's why I think it's so important because oftentimes we are misdiagnosing the condition. And if we're a little more aware of it and identify it, maybe we can use treatment strategies that are more effective and spare the patients from some other treatments that they may not need.
Can you tell listeners a little bit about how you practice rheumatology? Because I think you have an interesting lens in why you're the one that is diagnosing patients with CPPD.
Yes. And that's a good question because sometimes I always wonder, well, am I overdiagnosing it? And it's a higher prevalence in our clinic because we run the musculoskeletal ultrasound clinic. And so at MGH, we're lucky that we can have patients triaged. So we're seeing all types of arthritis. And within those, there's a large population of crystal related arthropathies. And so we are able to diagnose them better. And because we scan many of our patients, because that's what they send them for, we are seeing these crystals in joints for patients that they're thinking just have osteoarthritis, rheumatoid, psoriatic. And another thing is that ultrasound is known to have superior sensitivity to diagnose calcific deposition in the joints or chondrocalcinosis. And so through all these things, we are seeing more and having this higher pool of patients with chronic CPPD or other variants of CPP arthritis. And also, we can see tendons and other soft tissue structures that others cannot see. And so, this is why our clinic is so rich in these patients, and that's why we're diagnosing it so much.
Super. So, when I send you a patient with OA to get a knee injected or to evaluate something, you're looking at it under ultrasound and saying, wow, no, there's actually like crystal deposition here. This is actually probably CPPD. How often do you think that happens amongst patients in our rheumatology clinics with, I don't know, seronegative RA or PMR? Or like what percentage of the rheumatology population do you think may be misdiagnosed?
So, that's a key question, and it's a long winded answer. One of the biggest issues with CPP apathy is that it's like a chameleon.
Hmm.
And we forget, maybe it's our fault. As physicians, we've taught everybody about acute pseudo gout presentation. In the USMLE, we get questions. Everybody's aware of it. But then we've forgotten that there are other clinical phenotypes. And so, like psoriatic arthritis, there are different presentations.
Hmm.
And so that's the part where we're falling behind. And so there's the acute presentation, and it could come through a pseudo gout presentation, which look exactly like your gout patient, or you can have acute presentations affecting the cervical spine, which is a term called crown den syndrome. But then there's also the chronic forms, and that's where things also become a bit tricky, where you have pseudo osteoarthritis or chronic CPP arthropathy with osteoarthritis, or there's the what they call pseudo rheumatoid arthritis, which also is a chronic form of CPP arthritis, but they have chronic inflammation, just like your rheumatoid arthritis patient. And then more rare presentations, like a Charcot joint, which is
Hmm.
something that I've seen just a couple of times in my career. But that is why it is so hard to capture these patients because we're not thinking of those. And so I think it's first important to create awareness of the different presentations. And then the devil is in the details. And I think we're going to talk about that later is how to tease out those mimickers. When is it PMR? When is it CPPD? When is it RA? And so forth.
Yeah. So let's talk about RA since, that's one of the first things you brought up, sort of the pseudo RA presentation. We have a ton of RA patients in our clinics. When should we be thinking that this patient actually doesn't have RA and may have CPPD?
Okay, so that's a very tricky question. We need to have a lot of clinical clues, but that is one of the biggest mimickers, rheumatoid arthritis mimicking chronic CPP inflammatory arthritis. And first of all, I think we should focus on the patients that we have diagnosed as seronegative rheumatoid arthritis because that is where most of our CPP, chronic CPP inflammatory arthritis patients will be. And they have done a few studies and they've seen numbers from up to 3.9% of patients that have been diagnosed with seronegative rheumatoid arthritis to have CPP arthropathy. And within your RA patients, if you break it down, for seropositive RA patients, they have seen that up to 10% may have CPP, chronic CPP arthropathy.
Hmm.
And if you look at the seronegative patients, then it could double up to 18% of patients may have CPP. And so, what are the clues that you can use to understand whether your patient has truly seronegative rheumatoid arthritis or CPP arthropathy? Well, first of all, it's the demographics. Calcium pyrophosphate arthropathy is something that is known to occur in older populations. You're looking for patients that are mid 50s, 60 plus. Okay, so these are patients that might have gotten their diagnosis of rheumatoid arthritis in what we call elder onset rheumatoid
Hmm.
arthritis at a late stage of their life. Other things, so the joint distribution is very similar to rheumatoid arthritis. It very much likes the wrists and the MCPs. But perhaps your patients with chronic CPP arthropathy will have more bony proliferation in the x-rays. So there's more like
Hmm.
osteophytic change. We do see that with RA, but not as much. And then when you look at the joint involvement within the hand and wrist, MCP2 and 3, which are also common in RA. But again, with RA, we tend to see more joint space narrowing and less osteophyte formation. Wrists, we have also the scaphotrapezium joint, or what they call the STT joint. If there's a lot of degenerative disease there, that is somewhat distinctive of CPP arthropathy. And then another thing that is quite common that catches a lot of the patients in our clinic is these are older patients that are failing treatments. So these are
Mhm.
patients that have tried numerous biologics, disease modifying agents, and you just see ongoing significant synovitis in these areas. So all of these things are things that kind of say, ding, 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 this patient may actually have CPP. And then we start our diagnostics and looking for the condition.
And are there some patients that actually have both that may have an autoimmune inflammatory like RA component and a crystal component to their disease?
Yeah, so that's more what they call the overlap, that they are truly
Mm.
unlucky and they have rheumatoid and CPPD arthropathy. And those are known to have more morbidity, obviously, because you have two inflammatory conditions. To make that diagnosis, I really like them to have seropositivity for RA part. And in the CPPD realm, I really want to have objective evidence of it. And the best situation would be if I can get fluid from a
Mm.
inflamed joint to confirm that there is also crystalline related CPP arthropathy or significant calcification on imaging. And I will see on ultrasound that the inflammation is centered around those areas where there's dense calcium pyrophosphate deposition to feel, okay, there is also something else going on.
Got it. Because I guess chondrocalcinosis is common in the elderly, and you can have RA with chondrocal and not have it not be sort of pathogenic. So you have to, what you're looking for is having those calcium crystals actually be a source of inflammation in patients with existing RA.
Exactly. And that's another conundrum when you were mentioning, like, okay, why are we
Mm.
missing it and everything? Because, yes, there's this other concept of chondrocalcinosis being asymptomatic, and they consider that another phase of the disease. Perhaps that may be evolving as they
Mm.
learn more and more about CPPD because we wonder whether it's really asymptomatic because these
Mm.
patients are patients that are having the chondrocalcinosis and we see it on x-rays. We say, well, it's not causing symptoms, but then years later they're coming with destroyed scapholunate ligament, and then that leads to that famous scapholunate advanced collapse wrist injury that is very common in chronic CPP arthropathy or osteoarthritis in other joints where you're not expecting to have
Mm.
osteoarthritis. So you really wonder how asymptomatic things were. Or if you follow them long enough, you will see that these initial silent calcium deposits are causing smoldering disease activity.
So we'll put a pause there because I'd be interested in your thoughts whether so should we be treating those patients. I remember asking Sarah about that, and she said at least per the guidelines, those patients with quote unquote asymptomatic chondrocalcinosis shouldn't be treated. But I agree with you. We see many patients with really advanced osteoarthritis who have chondrocalcinosis, and I always wonder what's feeding the fire.
I think right now the straight answer is no. To be honest, we are still in a relative primitive stage in understanding calcium pyrophosphate arthropathy. And so we don't know well what are the risk factors for patients to eventually develop disease. And we don't have effective treatments to halt further deposition of calcium pyrophosphate deposition disease, to chelate these deposits, or to gout to eliminate the calcium deposits. And so at this time, if they're not having symptoms, if we don't have really any treatment, and we haven't found a disease modifying agent, I think it's fair to say that we should just observe them and not intervene.
Yeah, makes sense. So we talked a little bit about the pseudo RA presentation. How about PMR? I think I may have seen a couple of patients that sort of present with classic PMR. and they just don't respond. And we later wonder, was it CPPD all along? What is
Yes.
it? How do we make that diagnosis of CPPD in patients that may have a PMR like presentation?
Yeah, so PMR and GCA actually, because both of
Mm,
these conditions, again, are things that we see in our older population. And so let's start with PMR. So, PMR, if you look, you will have a patient that comes older than 50 or 60 years old. They will have elevated acute phase reactants and they will have stiffness of joints, usually shoulders, hips. Your patient with PMR that you may or should think of CPPD that is misdiagnosed could be, for instance, a patient that is telling you that, oh, I've had PMR for several years and I've been on prednisone for 10 years and I can't taper off because then my shoulder pain reoccurs. And they do x rays and they see osteoarthritis and they think that it's the shoulder osteoarthritis is just because of age. And so typically our patients with PMR, we're not needing steroids for that long. The shoulders, if we think about it, are joints that are not supposed to develop primary osteoarthritis. So here we have a pseudo OA presentation of
mm,
CPP arthropathy. And also, at times, they can present with shoulder pain and stiffness, but their acute phases reactants are not that high. But you're like, it's the right clinical setting. And so I'll make the diagnosis of PMR. Remember, we diagnose what we know more, what we feel more comfortable seeing and treating. And so we'll direct the narrative when we do our
mhm.
HPI to fill those check boxes. And if you look at it, they have similar findings where you could make a diagnosis following classification criteria. But what are like clinical pearls? So, as I said, PMR, if you talk to a true PMR patient, they will talk about gradual malaise, fatigue, a rather abrupt change in their functional status, which is something that you don't see in PMR. So they just have shoulder pain or
Mm,
hip pain. They have some morning stiffness, but usually it's not 1 hour as we're seeing in our true PMR. So there's a more abrupt change of things. Yes, PMR, CPPD can have acute flares, but those are more transient. So PMR symptoms are different in that way. And elevations in ESR and CRP are more frequent in PMR. But yes, there's a 10% of patients with PMR that may come without acute phase reactant elevation. That is more the scenario that we see with CPP arthritis, less elevations in acute phase reactants where they have that pseudo OA presentation.
yep.
And I mentioned GCA because that's a common mimicker that we, in retrospect, sometimes see that could have been misdiagnosed. So, again, you have your older patient, they had headaches, they had elevated acute phase reactants, but all the tests are negative. Again, then you start looking for other things, peripheral joint involvement, negative tests. Those could be presentations of Crown-Dens syndrome because they don't have that pre-disease stage of malaise, fatigue, and stiffness. And so that's like the clinical clues that you can use to distinguish one from the other. And again, once you think about it, then you screen and look for calcium deposition in different joints.
And is that something that you would see, for instance, on radiographs? If you get radiographs of the shoulders and hips, should you see some calcification around the joints in patients
Yes,
that
you
have
can.
CPPD?
So when you really just can't get fluid anywhere to make a crystal diagnosis, then in the radiology realm, they tell us to do x-rays of other classic areas where you
Mm,
would find calcium deposition disease. So that would be like your wrist, your knees, some call the pubic symphysis area in the pelvis.
hmm,
But in ultrasound, we could see that and in other places. So we could look for it in the AC joint. We could look for it not only in the triangular fibrillar cartilage of the wrist, but also in the scapholunate space that also has in the shoulder. We could see it also in the labrum, in the hip. We could see it also in the labrum as well. So areas with fibrocartilage that we can't see that well in x-ray, sometimes we can also identify with ultrasound.
amazing. Are there presentations of the spondyloarthritis or psoriatic arthritis that actually may be related to CPPD?
So, good examples of that would be so axial involvement, sometimes they can have quite significant degenerative findings and calcific deposition. And so the patients will have, when older patients, it's always harder to distinguish inflammatory back pain from mechanical. And so that's one thing that is a little challenging. But Oftentimes they may be diagnosed with spondylo because they have a lot of axial symptoms and morning stiffness, but they typically won't have inflammatory markers. And for
Mm.
psoriatic disease, calcium deposition can also occur in the tendon and thesis. And so sometimes
Mm.
these are older patients that have pain and you're scanning them and they have what is seen in psoriatic arthritis, which is like calcification at the enthesis, and they may have Doppler signal if it's flaring. And it makes it a little hard to distinguish, well, is this a patient that has calcium pyrophosphate deposition disease, or is it more like a late diagnosis of psoriatic arthritis? So those can be quite challenging. Also with the hands, where we see erosive osteoarthritis with a lot of osteoarthritis and some inflammatory features, that can be a bit challenging
Yeah.
in some of the cases.
Yeah. Are there any other diseases that we haven't talked about that we should, where we may be misdiagnosing CPP arthropathy?
So those are the more common mimickers. There's always a question whether, okay, is this pseudo gout or is this gout?
Hmm.
And
Of
that comes
course.
up at times. Most of the
Yes.
time, it's more simple to distinguish because they have different risk factors and it's different demographics. But at times, you have a patient with a swollen joint and you can't get fluid. With ultrasound, you can most of the time make the distinction between gout and pseudo gout, but sometimes it's not as straightforward. And so we'll have to use again, all these clinical clues that I talk about. Look for risk factors for gout, look for risk factors for pseudo gout. And then rheumatologists are animals of pattern. And so we do that also with ultrasound. Yes. And so we are looking for joints that are more frequently involved with gout or pseudo gout. So if you're highly suspecting gout, then I'll screen that first MTP. We could do the knee, the distal ankle, the Achilles tendon insertion. But if I'm thinking of calcium pyrophosphate deposition disease, then I'm looking at other sentinel joints. So we do this, what is called point of care ultrasound. And what that means is we'll kind of adapt the ultrasound used to whatever's needed right there in the office. And so we can scan multiple joints. And for the calcium pyrophosphate deposition disease is what we said, wrist, definitely, knees, and then you go with these other joints like shoulders. Elbows can actually be an area where you have CPPD because at the lateral joint line, there's a mini meniscus, which is fibrocartilage, and there's a strong affinity of calcium deposition in fibrocartilage. So we can look there and all the other sites I mentioned.
So as a rheumatologist that doesn't do musculoskeletal ultrasound, how should I think about sort of evaluating patients with these various presentations? The most important thing is recognizing, this could be CPPD. What should be the next step? For instance, a patient that presents with pseudo RA, PMR, that it's not clear whether it's PMR, or as you mentioned, psoriatic, that may not be psoriatic. How should I begin to sort of evaluate these patients? Should I try to get fluid or send to imaging? What are your thoughts?
If you don't have the capabilities of having ultrasound or the fortune of having good friends or colleagues who can see the patients for you and find it, then what you could do is you could start a good physical exam and history are always important. And then
Yep.
you look for involvement in these other areas, joints, hands, wrist, x-rays of the joints that we said, if you're really looking for it. And whenever you have fluid, you should always try to obtain fluid because that is the gold standard. And it's always good to confirm things when we're selecting treatment. And if not, then you can have someone to do ultrasound that could increase the likelihood of diagnosing the crystals, obtaining fluid from difficult sites. That would be like your large joints, tendon sheaths, and things like that. So we could confirm a diagnosis.
Yeah. How does the sensitivity and specificity of ultrasound compare with like synovial fluid analysis for CPPD? Like, do you have higher or lower sensitivity?
So that
What's your
has been looked
sense?
at by the Europeans, and I don't have the numbers, but one thing to keep in mind is that it's not that far off from synovial fluid. And the reason is CPP is a little trickier to diagnose even with crystal microscopy,
Mm.
with microscopy, because they're a little less reflective. and not as birefringent. And it's more common to have a false positive in CPPD than gout. Gout
Hmm.
crystals are extremely bright, reflective. And so at times you will hear that even the synovial fluid conformation has its issues. And it's not uncommon for patients to
Hmm.
get diagnosed after serial arthrocentesis.
Yeah.
And so
Makes
complementing tests always helps. But yes, even synovial fluid has its flaws.
Yeah. So as an ultrasonographer, how do you go about when I'm referring, I've done this many times. I have a patient, they have, I don't know, seronegative RA. What's your process of evaluating that patient with ultrasound to try to sort out what's going on?
So we'll always focus on the symptomatic joint. And within the symptomatic joint, that's the beauty of ultrasound. For instance, if a patient comes with wrist pain, when we examine, we just know, okay, it's the wrist. But within the wrist, for instance, or in many other joints, there are different compartments. So within
Hmm.
that same wrist, we can see if it's the radiocarpal joint or the midcarpal joint that has the synovitis or fluid, the ulnocarpal joint, the tendon sheaths, and all of these areas. So we're looking in all these segments. And so those are pockets that we can use to make a diagnostic arthrocentesis
Hmm.
or also treatment wise. That's the beauty of ultrasound, that we can provide more targeted treatment. So we always scan the joints that are being evaluated because we will inject the steroid in the areas where the inflammation is being condensed. And
Hmm.
so that I feel also is more helpful when we could be more selective of where we introduce our steroids, where we're sampling, and things of that nature.
Yeah. And how often, if I refer a patient to evaluate the hands, you mentioned about thinking about evaluating other joints, like the knees, if you're concerned that the patient may have CPPD. How often do you look at other joints as you're doing your evaluation to try to get more data?
So time is always a big factor. Everybody has this problem. And so obviously the more areas you scan, the higher yield that the evaluation will have. However, if they send you for a specific joint that has symptoms, and if you get all your answers there, then I don't need to be doing other joints. So that happens more when I cannot get the answer with the joint they're sending to evaluate. I can't get fluid, or maybe I'm just seeing pure synovitis and really I'm not seeing calcific deposition. Then I have to look in other areas. So that's the treatment paradigm that we do. We'll start with the main joint, and if we don't see, then we'll ask which others hurt, and we'll try to look for other joints that may have calcific deposition. And it may be that when you're looking for it and you ask the patient, they say, well, yes, my shoulder hurts, or I've been having elbow pain and things of that nature. And then you can also tie in the symptoms and the findings better to make a diagnosis of calcium pyrophosphate arthropathy.
And I guess one of the things that you mentioned before that it's important to highlight is that you're not only looking for the crystals, but you're looking to make sure that the crystals are sort of that there's inflammation around the crystals and that the crystals are causing issues, not just chilling out in the cartilage doing nothing.
Yes, that would be equivalent to saying, okay, when you aspirate fluid, when they tell you, like, okay, the calcium crystals are intracellularly, then it's like,
Mm.
okay, that's the definite evidence that these are the ones causing the problem. So when we're seeing all the inflammation, we want to see it where the crystal is. If it's not happening in that location, then seeing it in other areas increases the diagnosis, but there's a little less certainty then of an association.
Yeah. And I also wonder about for some of us that don't do musculoskeletal ultrasound, you mentioned, well, you should tap the joint. Sometimes that's hard when you don't have ultrasound. So, how does ultrasound help you in those areas when there is some swelling? Like, how often do you go at it with a needle? When do you think about doing that?
Yes, and that's a kind of
Mm.
like a general concept for ultrasound outside of CPP is that our physical exam has limitations. And so, particularly for large joints, we can't really know what's going on. And so, for ultrasound, we can see which is the structure that is having inflammation. And like for tapping the joint, as I said, shoulder pain, we say, oh, it's restricted range of motion. You don't know if there's arthritis. You don't know if it's a frozen shoulder. When we scan, you can see that we've taken fluid out from biceps tendon sheath, which I
Mm.
think it would be very challenging to get without having ultrasound guidance. Even the shoulder joint, aspirations of the glenohumeral joint are not that easy. They can be humongous, and that's where we can get it without guidance. From the bursa, the subacromial subdeltoid bursa, we were taking fluid from those areas. So these are sites where you can get fluid without having guidance, but there would be cases where it's a large fluid buildup. But we can get even smaller, like we can get 1 cc if needed for the diagnoses.
Hmm.
We have to keep in mind that there's some degree of what they call sympathetic effusions at times. So you may say, like, you may see chondrocalcinosis in the labrum, the AC, and take fluid from the subacromial subdeltoid bursa and not see the crystals. And I wouldn't fully exclude the possibility because, again, this happens at times. Even with gout, you're getting fluid from a site that's adjacent and reactive, but not the site with the crystals. So again, you have to put the whole clinical picture into context, as with anything with medicine and more with ultrasound.
Jeanette, I think the hardest thing for me is thinking about when I should be referring patients to you for musculoskeletal ultrasound. What are the sort of patient scenarios that you think would warrant evaluation for CPPD with ultrasound?
So I think if you have a patient where you do not, where you have a diagnosis, for instance, of a seronegative arthropathy, or if you've classified them before as psoriatic arthritis, where the diagnosis and the response to treatment is probably not fitting well, it wouldn't hurt to send them for evaluation for that additional layer of assessment to see if there's calcific deposition triggering the chronic inflammation. Another common scenario that we get frequently is these are patients that have a significant amount of secondary osteoarthritis or more
Hmm.
advanced osteoarthritis because of their disease. And so it becomes very hard for the patients, for us who are seeing them, to tease out how much of the pain is degenerative, how much of the pain is inflammatory, which are the structures that are hurting. So that's also a very useful way to use our musculoskeletal assessment to help expand the care and the treatment that you folks can provide.
Yeah. One of the challenges of making those referrals is that you guys are really busy. And sometimes I struggle whether I should send patients to you and the musculoskeletal ultrasound clinic, or if I should just send my patients to radiology for ultrasound evaluation of their joints. What do you think the differences between how you approach ultrasound and how a radiologist may approach ultrasound?
So that's great. And it's very good that you asked that. And before I go in depth answering that question, I think also one thing I wanted to comment is to overcome the access problem. In our institution, we have integrated nurse an APP and we've trained them to perform these type of assessments and procedures. And I think you interviewed one of our nurse practitioners. And that's something that I would also promote for different departments to consider that, to unload the access issues.
It's a
And
great
then
point.
your second question, what is the difference of sending a patient to just IR versus us? And what I like to say is that we provide a more holistic assessment of the joint or the arthritic process. When you send to IR, you say, inject the wrist. And in that scenario, they're functioning as technicians. You send them for a wrist injection, and that is all they will do. When they come to the ultrasound clinic, we do a whole HPI, we examine them again. And so we might change somewhat what you requested depending on what the situation calls for. And so not only that, when we examine the joint, we are looking at different structures. So an assessment of the shoulder, the wrist, even the ankle. We're finding exactly if it's in the tendon, if it's in the joint, which joint compartment is the one that's causing the problems. We can better assess if there's fluid for diagnostic arthrocentesis, which will not necessarily be done by IR if you don't specifically request it. And so these are all the other things. So once everything is changed, the assessment, the impression, we can provide some recommendations. We can treat there with injections on site with point of care ultrasound. So those are the main differences. And I find that patients really love that rather than just going to a place. It's more kind of more informal. They go, they get injected, and they walk out.
Yeah. I mean, that reminds me a lot of search in Google versus ChatGPT. That ChatGPT just provides you with much more information and nuanced understanding than, the previous Google search.
I
That's
like
great.
that we're compared with higher level technology.
You sort of spend a lot of your time in sort of diagnosing patients with CPPD. Why do you think it's so important to make that an accurate diagnosis of CPPD? What are
Well,
the consequences if you don't?
Well, for various reasons. First of all, the knowing that your patient is not responding as desired because they may have chronic inflammatory CPPD arthropathy is really important to manage expectations, both for the patient and for the provider, because this is a condition that very early in the treatment stages, and we don't have disease modifying agents. Even the current biologics that are repurposed for the use of chronic inflammatory arthritis don't work as well as they do with the diseases that they're designed to treat. And so it becomes very frustrating for the patients, for the doctors, that they keep on coming back with synovitis. And so for prognosis, it's very important that you know that there's that additional component to their arthritis. And you know that if you're cycling biologics, what to expect, you can select some better than others. That have been some research identifying these biologics as to have some role in controlling this form of arthritis. So I think that is one of the most important reasons, because patients get frustrated. Also, these will evolve sometimes into end stage joint damage, needing more arthroplasty. And that's one of the consequences. So when we come up with effective treatments, it's good to identify them so we could prevent these numerous arthroplasties that these patients are getting, because it's not uncommon for you to hear they've had spine surgeries, 3 or 4 arthroplasties because of their disease. The
Yeah.
other reason is if you could prevent and identify structural damage. CPPD, chronic inflammatory arthropathy, are typically thought as being a non erosive disease. Well, in fact, some of the patients can have erosions, and that will present clinically as a lot of deformity, joint damage. There's cases where they present with spontaneous tendon ruptures. That is not frequent, but not uncommon presentation. And just the chronic inflammation just affects the health of the tendon, and they can snap with minimal impact. That happens in the hand joints. Even the biceps tendon is a scenario where we see at times. They also can have chronic nerve impingement from chronic synovitis in the wrist, the elbow, causing impingement of the median and ulnar nerve. And so these are all the things that are important to keep in mind so you can better understand, guide the patient, send referrals when appropriate. And as I said, when effective treatments come out, then we can direct them and hopefully send them earlier to avoid all of these complications.
Yeah, that makes a lot of sense. I really like your idea about setting expectations. Like you mentioned, we're pretty good at treating rheumatoid arthritis and psoriatic arthritis, but I guess we can't expect to achieve those same outcomes in some patients with CPPD because we just don't have targeted treatments like we do for the other conditions. Can we change the outcomes of these patients if we diagnose them appropriately? So, what's your treatment paradigm once you diagnose patients with CPPD in your ultrasound clinic?
That's an interesting question. So remember, these are patients that will have chronic synovitis. And in comparison to rheumatoid or psoriatic arthritis patients, sometimes it will present with episodic acute on chronic flares. So the question is, how do you treat the chronic part and how do you treat these flares? So the acute flares, they're treated with everything we use for pseudogout or even for gout. The same cocktail, they all work for the acute flares. So we typically will start with the less side effects and ramp our way up depending on whether there is a contraindication or patient does not tolerate. And I'm not going to spend time talking about those because everybody knows what those medications are. Now, for the chronic type of CPPD, we'll again repurpose some of our medications. So there is literature that talks about colchicine for CPPD in general, not specifically chronic inflammatory CPPD, but because that is what is a main indication of it, we try it as a first line at times because it has low side effect profile. I did want to mention that someone at our joint institution at the Brigham will be starting a study with the use of colchicine for, I believe, for chronic inflammatory arthritis. My personal experience is that it helps with the acute flares. It may decrease the frequency of the acute flares, but controlling the chronic synovitis it has a more limited role.
What are the typical doses that you use for colchicine
Yeah, so for
for
the acute flares,
prophylaxis?
and if they're not already on the colchicine, I will tell them to somewhat saturate the system with 2 tablets at once and then continue once a day. Remember, these are older patients, so many will have low GFR and be on other medications that might interact with the colchicine. So we're being a little careful about those things. But if they tolerate, then if you could do 1 or 2 a day, that's perfect. I always tell them to monitor for diarrhea. You usually would not have the more concerning side effects without passing through the process of diarrhea. So, cytopenias, muscle inflammation, that should not happen if they stop the medication when they have diarrhea.
And then
And
you were going to mention colchicine is sort of first line, works a little bit to prevent flares. What other tools of the trade do you use?
yeah, so there's also literature on hydroxychloroquine. It's just anecdotal and it's not consistent. The results, personal experience has been the same. But again, because it has a low side effect profile, it's also in the list of possible medications to use for the chronic variants of CPPD. Then they talk about methotrexate. There have been a couple of trials with mixed results. So some folks advocate that the dose wasn't maximized to a 20 milligrams per week as we use at times. It's a little hit or miss, but there is some role in using it as a steroid sparing agent because luckily the disease responds very well to steroids. It's just we can't have our patients on steroids forever. So definitely something to try if your patient is needing moderate or consistent steroids. But if it even continues and is very symptomatic despite that, keeping in mind that we won't get them into remission, but to a state where the inflammation is simmered down and they're less symptomatic, then if they're still symptomatic and having a lot of symptoms and pain, we will move on to biologics. And TNF blockers are not typically something that are used. There's very few studies on that, but there's more and more literature on IL-1 blockade because it is known that the crystals have the same pathway as gout. And so we're trying to block the inflammasome. It works very well for acute CPPD. For chronic CPPD, again, mixed results. And more recently, the Europeans are working a lot on using interleukin 6 blockers for chronic inflammatory CPPD. So we don't have definitive results and nothing to solidly recommend it consistently, but these are the options because these are patients that are coming to you with very prominent synovitis, very symptomatic. And so we have to offer some options for them.
When do you consider glucocorticoid injections as part of the treatment? Is that for acute episodes, chronic, or both?
So we do both. And I do have to confess that at the ultrasound clinic, we are very aggressive with corticosteroid injections because our goal is to minimize the oral systemic load of steroid. So in patients that have large joint involvement, if possible, and the patient agrees, we will always favor intra-articular injections. And even in patients when they have polyarticular involvement, if I inject the most of inflamed joints that are to reach, like a knee, a shoulder, an ankle, then I can minimize how much oral steroids I give for the inflammation of the small joints of the hands. So that does work well with many of our patients because we might find that they come frequently and we're needing to expose them to steroid with quite frequency.
Very good. And then in terms of treatment, is there a role for surgery? Do you ever refer these patients to our orthopedics colleagues for management of CPPD?
So definitely when they've reached a point where they have advanced osteoarthritis and end stage joint disease where really there's no medication that, and even if there's a significant amount of inflammatory synovitis or tenosynovitis, the joint is at a point where there's not much benefit in using systemic medication. So arthroplasty would be the way to go. There's something that we have to remember and that we haven't established good treatment paradigms is these are patients that are rupturing tendons and ligaments. And The scapholunate ligament is a very common area where this disease will cause problems. So once it ruptures the scapholunate ligament, the space opens up, and many of these patients will present with what is called the slack wrist, the
Hmm.
scapholunate advanced collapse damage in the wrist that promotes to osteoarthritis. So in the future, it would be good to see if there's any way to prevent, or in a patient where you see bulky deposition, if there's surgical options to prevent this damage, because once the arthritis has developed, then the options for surgery are more aggressive things that like a fusion or things of this nature. Another scenario that I see a lot is patients that have chronic recalcitrant carpal tunnel syndrome. And what tends to occur is they have like tumoral calcinosis, where there's large, bulky deposition of calcium pyrophosphate crystals with surrounding granulomatous tissue deep to the flexor tendon. So all of that is there compressing on the carpal tunnel, and it's a mechanical mass effect that doesn't get better and will cause chronic nerve damage. So at times I've sent patients for carpal tunnel release asking the hand surgeon to try to do a synovectomy, and I send them images of how much synovium and calcific deposits they have deep to the tendons, because this is something that is not routinely done.
Yeah. What we've discussed so far is that overall, CPP arthropathy may be underdiagnosed, that it's really important to diagnose it. There may be some treatment options that we offer patients, but sort of those options are limited. They're not as effective medications as we have for other of our inflammatory arthritis. And that for some patients, they need surgeries because of joint damage or joint destruction. So it sounds like we have a ways to go to optimize the treatment for our patients with CPPD. How do you envision the future of CPP arthropathy over the next 5 to 10 years? How do you think the field will change to try to improve the care that we provide to these patients?
So I think right now we are in a stage where we are really trying to create more awareness, and there's groups that are getting everything ready to have good systems, once effective treatments to not only control the inflammation better, but to find ways to avoid accumulation of the calcific deposits. If there's anything that can chelate or eliminate those crystal deposits equivalent to what we see in gout, like an
Yeah.
allopurinol equivalent that has not been found yet. And there are groups working on that. That would be helpful. And then also this advanced imaging. We know that it now, in the recent classification criteria, they've identified the role of advanced imaging for earlier detection, which will
Hmm.
hopefully help in the future. And then to assess response. So once these medications are identified, assessing what's the DAS in a patient with CPPD, we need to look at the joint count. We need to look at structural damage. We need to look at the surrounding inflammatory findings like RA. So I think there's a lot of room for progress in this field. But yes, the most important thing is to create awareness and have pharmaceutical companies invest in doing more research that is very much needed in this field.
Amazing. Jeanette, this has been an awesome conversation. Thank you so much for your time in talking to me and to our audience about the lack of awareness of CPPD, how ultrasound can help to diagnose these patients, and some of the treatment approaches that you do in your clinic. Thank you so much for your time. And thanks again for evaluating and helping me manage many of our patients with CPPD.
My pleasure. Well, thank you for having me. It was a pleasure to be here.
Today, we discussed why chronic inflammatory CPPD is often hiding in plain sight, masquerading as seronegative rheumatoid arthritis, polymyalgia rheumatica, psoriatic arthritis, or even osteoarthritis, and how musculoskeletal ultrasound can help uncover the diagnosis. Dr. Yin challenged us to think of CPPD not only as a disease that causes recurrent episodes of inflammatory arthritis, but as a chronic disease that can mimic other rheumatic conditions and contribute to joint damage. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep CPPD on your differential.